VBG, ABG, CBG. Do we know our way around them? When should we use one over the other? How do we interpret them all? And are we using some of these too much or not enough? Your critical patients need you to know this.
You make tough calls when caring for acutely ill and injured children. Join us for strategy and support through clinical cases, research, and reviews, and best practice guidance in our ever-changing acute care landscape. This is your Pediatric Emergency Playbook.
Welcome to the Playbook. I'm your host and coach, Tim Horechko. Blood gases can be a bit of a pain for us to interpret and to obtain, and more importantly, potentially for our patients, literally. In children, when do we need an arterial blood gas, and when can we use a venous blood gas? There is a consistent relationship in values between ABG and VBG. I have a conversion that you can use at the bedside, and more on that later. First, let's look at the evidence. This is a great example of a topic whose evidence has evolved over time. As a background, there was a lot of resistance in using VBG in place of ABG because, well, tradition. Byrne et al. In 2014 in the Journal of Respirology did a systematic review and meta-analysis of the comparison of venous and arterial blood gases. Now, you can see how this may be somewhat of a non-starter. How often are they going to find studies in which the same patient got both arterial and venous gases at the same time? Well, there weren't any studies that did this, so they had to do the best thing. If you have a group of people that had ABGs, then you need to have a group of people who had VBGs, and those groups need to be as similar as possible to each other so that, all things being equal, the only thing that is practically different is the type of blood gas. Really, it's almost impossible to do. And that, my friend, is research in a nutshell. No study is perfect, even if it were designed prospectively to be perfect because, well, life. The investigators only used case-controlled studies that were consecutive series of patients. So, just to refresh our memories, a case-control study is when you have a case, which is someone with an exposure or a feature that you're looking for, and a control who is as similar as possible to the case except for that feature that you're looking for. So, for example, if you have a case that is a 35-year-old man with pneumonia who has an admission ABG done, then you have to find a control that would be as similar to him as possible. So, a 35-year-old man with pneumonia and a VBG done. Easy, right? Well, you can see the difficulty in trying to match people very well. Even if this were a twin study, there's still some confounders that just may influence the data in ways that we don't realize. Keep this in mind as we go through this study. The advantage of case control studies is that being retrospective, you can conduct them pretty quickly and ask questions that otherwise wouldn't be answerable because conducting the study would be prohibitive in cost or time or feasibility. Byrne et al. Enrolled patients 16 and older. They looked at the pH, the PCO2, the PO2, and various other things. To analyze the differences between ABG and VBG in these values, they used the Bland-Altman approach. When we want to compare the agreement between two quantitative methods of measurement, we need to know the amount by which they differ, otherwise called the mean difference. But we also need to know the limits of how far they will agree with each other. So, the limits of agreement. So, as an example, two types of measurements of, say, pH in ABG versus VBG may not vary when they're in the normal range. And so the mean difference will be small, and you conclude, hey, they're really the same. And that's okay, but you also need to know and measure the difference between them across the whole spectrum of values, from the very low to the very high, to see whether or not there's a divergence. For example, when the pH in an ABG or VBG agrees very well when we're, say, in the 7.2 to 7.4 range, But maybe we get to the 7.0 to 7.2 range and they start to vary quite a bit. Both of those pieces of information are important. The mean difference between the measurements and also the limits of agreement. So to be clear, to see whether these two methods of measurement agree with each other, we need to know by how much they differ or agree, the mean difference, and over what range they tend to differ or agree. Ideally, the mean difference is low and the limits of agreement are high. So the mean difference is low no matter what the values are. Okay, before I lose you, this is important stuff because first we need to expand our statistical repertoire, and this is a seminal paper by Bland and Altman. It was ranked number 29 out of the 100 most cited articles in Lancet. Go figure. But just from a self-protection standpoint, it's also going to be on your board exam. Anyway, the Bland-Altman graph looks like the result of target practice. The difference between two measures is on the y-axis. So the y-axis shows how the ABG and VBG values differ. The x-axis is interesting. It's the average of the two measurements. Ideally, both the mean difference and the average of the two converge in a cluster of data points right in the middle of a graph. Check out the show notes for an example. Now, all of that may have just sounded like Don't worry. If this isn't your thing, I just want you to have heard about it if it comes up in an article that you need to read. Okay, so the researchers looked to see how well these two values converged. And after all of that, there was still a major hurdle that the researchers found, that of heterogeneity among the studies. When we do a meta-analysis, we try to choose studies that best fit our predetermined parameters. We can then pool all of the data gathered by different people with different backgrounds at different institutions at different times, etc., and hope that we chose studies that are similar to each other as much as possible. The reason to do this, of course, is to increase the power to find a potential difference. Think of it this way. If each of us wanted to do our own study on this, and we worked very hard individually to find 25 patients, maybe 50 patients, maybe you were really great and you got up to 100 patients, but we were never really able to prove or disprove our hypothesis. It may be just the fact that we're underpowered and the outcome we're looking for just needs more people. So if we all have very similar study designs and we work with the caveats that are the differences between the studies, we can actually dump all of our data into the same database, perform a meta-analysis of all our separate individual studies, and presto, now we have 600 people we can try to make conclusions with. This is a meta-analysis in a nutshell, and you can already see how that nut is a little hard to crack. Every meta-analysis has all of these caveats, and that's sort of what research is. You do the best you can with what you have, and you put in all the caveats and all the limitations and all the discussion and understand what is the value of this information in front of you. And then at the end of the day, you have to make some kind of judgment on whether or not this information should and can change your practice. So the researchers in this case, the Byrne et al. Article, after all of that hard work, they couldn't find much of a correlation between the ABG and the VBG. Now, that may be because, according to them, there was no correlation, or it may be because the study designs were all just too different and there were lots of competing confounders that made it difficult to see the signal behind all of that noise. And that, I believe, is what happened here. To test the validity of the meta-analysis, they did what every good statistician would do, which is to perform a test for heterogeneity, how much the studies will differ from each other. We can do this quantitatively. What you do is you take a measure of the variation of findings, so the range of values, and you look at the variation across all of the studies. Ideally, there isn't much variation among studies. Ideally, they all find similar things, and it's just a matter of pooling all of the information together, all of the data points, to create a new study, a new meta-analysis. But if there's too much variation, there's too much noise and not enough signal. And so what you end up finding is you pick up more of the distraction. You find that there isn't really any statistical significance between the two. So this heterogeneity between studies, this measure of how much these studies differ, and therefore maybe this wasn't a very good pooled data set, this is measured by the I-squared statistic. It's the percentage of variation across studies that is due to heterogeneity rather than by chance. Ideally, the I-squared statistic is low. In this meta-analysis, there was a high heterogeneity, meaning the studies differed among themselves, so any conclusion when you pool all the data is difficult and fragile. Okay, no more stats, I promise, but you're still welcome. So at that point, Byrne et al. Made the conclusion that they just weren't able to find a correlation, and that's fair based on what they did. The next step in progress towards figuring out whether there is a correlation between ABG and VBG can be found in an article by Kelly et al. In 2014 in the Emergency Medicine Journal. They applied what was a previously developed formula for converting venous blood gas measurements to arterial measurements. They called it mathematically arterialized blood gases. They had this previous calculation that they had already worked with. Then they did a retrospective post hoc analysis of a prospective study. Okay, I know I said no more stats, but just bear with me for a moment. A prospective cohort study was already done for patients undergoing non-invasive positive pressure ventilation. These researchers were wise to get both venous and arterial blood gases during that prospective phase. Kelly et al. Went back to use that same data. What they did was they took the VBG and they converted it mathematically to what it should be as an ABG. And then they compared that mathematically arterialized VBG to what the actual measured ABG was. They found that the converted VBG values correlated extremely well. In other words, this study concluded that a conversion is feasible and valid. A huge leap forward for the use of VBG in the ED. Subsequent studies have shown the reliability of a conversion factor, usually described in a range. For example, the arterial pH will be approximately 0.03 to 0.04 units higher than the venous sample. The arterial PCO2 will be approximately 3 to 8 millimeters of mercury higher than the venous sample. Now, trying to remember that and trying to remember what range which one is can drive us all crazy, and it's so hard to remember. So here is my rule of thumb. Are you ready? When interpreting a VBG, we know that the values will not be as high as the ABG. ABG is king, we get it. But sometimes the king is just not available or is too painful or is not feasible. So here is my rule of fours. The pH between VBG and ABG will vary by 0.04. The PCO2 between VBG and ABG will vary by 4. And the PO2 between the VBG and the ABG will vary by 40. Okay, the last one is a bit of a stretch. No one is going to use an isolated PO2 from a VBG to make big decisions. That's just not what the VBG is for. But it can come in handy to know. For example, in sepsis, there is terrible end organ oxygen utilization due to metabolic dysfunction at the capillary bed level. There's a poor oxygen extraction from the RBCs. So, if you were to get a simultaneous ABG and VBG, and you were to compare the PO2 on each, the PO2 on the VBG should be lower than the PO2 on the ABG, right? And it should be lower by at least 40, right? So if there's not much difference in PO2 values between the ABG and the VBG, then you have poor oxygen extraction and severe sepsis with increased morbidity and ICU utilization. Okay, that was a quick tangent to reinforce the rule of fours. pH on VBG will be lower by 0.04. So really negligible, right? We can say that clinically they're the same. The PCO2 on VBG will be lower by, that's right, 4 millimeters of mercury. Also not a huge deal as long as we know the variation, but it's a nice, useful piece of information, especially with the initial resuscitation. And finally, the PO2 on VBG should be lower by at least 40. 0.04, 4, and 40. VBG is lower than ABG. Got it? Now you have a powerful tool at the bedside to interpret VBGs. You also have a powerful tool to advocate for your patients not to get an ABG if you just need to know the pH or the PCO2. Okay, when would knowing this come in handy? The most common thing that comes to mind is for diabetic ketoacidosis. You'll likely want to know the pH to verify the diagnosis or to understand the severity of the DKA. Remember, in DKA, we're looking for hyperglycemia, metabolic acidosis, and ketosis. The specific parameters are these: a pH of less than 7.3 or a serum bicarbonate of less than 15, hyperglycemia with a glucose of at least 200 or more, in the setting of glycosuria or ketonuria. Now, I'm sure that you've seen patients who are in DKA with a bicarbonate of 15 and above. You know, some people just smolder in their DKA for a while and then seek attention, and some go from well to ketotic in a few hours. When the bicarbonate doesn't qualify, look for the pH. Now, if I haven't convinced you yet of the utility of pH in DKA, it's further recommended to use it to track the severity of illness. Mild DKA is 7.2 to 7.3 of pH. Moderate is 7.1 to 7.2. Severe DKA is defined as a pH of less than 7.1. The pH of the VBG is 0.04 less than the arterial. Really, for all intents and purposes, it's the same. So that is to say, in whatever condition or whatever patient, the arterial and venous pH are clinically the same. And this only makes sense physiologically. You can't cycle through pH from heartbeat to heartbeat. PCO2, however, has a few caveats. The venous and arterial values for PCO2 do not correlate well in a shock state, as we talked about earlier. Also, remember we talked about needing to know the correlation across values, both high and low? In this case, in hypercarbia, you start to see more of a divergence between ABG and VBG, especially when you start to get above the 45, 50, and 60 millimeters per mercury range. But you know what? If you are hypercarbic by VBG, you will be hypercarbic by ABG. The actual correlated number may be off the higher that you get, but you may not need to know the actual number. We know that in hypercarbic hypopnea, the actual PCO2 value is not as important as the clinical state. Think of this as the ammonia analogy. It's either elevated or not, and we can't read into the degree of elevation to predict mental status changes or whether we intubate a patient. But if you want to get closer to a real correlation of PCO2 and you don't want to stick that little artery, you can use the end-tidal CO2, right? With end-tidal CO2 monitoring, remember that it correlates well with the arterial PCO2 by 1 millimeter of mercury. So the nice thing about this is it's non-invasive, it's continuous, it's immediate. Which brings us back to another way that we can use the VBG. You'll use it in the child that you suspect has DKA. That's a no-brainer. But what about the child who comes in acutely ill for no other cause? You have a child that comes in who's ill, who is potentially altered. You do a point-of-care VBG and show that the pH is 7.34. Okay, The PCO2 is 50. Hypercarbia, that must be relatively acute given a relatively normal pH. So maybe that was hypopnea that is now resolved with ongoing altered mental status. Was this a seizure? Was he just postictal now? Or maybe you have a child with altered mental status and no other history. That happens too, right? You do a point-of-care VBG and his pH is 7.28. His PCO2 is 50. He feels warm to touch. Is this sepsis? Okay, that's all well and good. VBG is great. We got it. When do you use an ABG in children? Truthfully, almost never nowadays. Even in adults, a lot of what we need to know that is non-respiratory, we can get from a VBG. Even in adults, checking the ABG in spontaneously breathing patients will only make you do things that you probably shouldn't do, like intubating an asthmatic who can still breathe on his own and can still communicate with you. Since adults have had more time to accumulate diagnoses, and there may be a mixed picture for the respiratory distress, we may need an ABG to check the AA gradient. Remember this? It's the difference between the alveolar oxygen concentration and the arterial oxygen concentration. Ideally, there's not much difference. There is a normal fixed physiologic difference so that you're able to perform gas exchange, but the oxygen in the air in your alveoli should move on over to your arterial system without much fuss. When you have hypoxia, especially in an adult, and you have no idea why, it doesn't seem to be reversible, like in asthma or COPD or maybe even heart failure, or not readily reversible in a known pneumonia, then you probably should do an ABG to see if there is a difference in the alveolar and arterial oxygen concentrations, an AA gradient. You measure the arterial PO2 and you compare it to what the oxygen concentration should be in the alveoli. So you'll have to know what the percentage of FiO2 is used. Remember also, the AA gradient naturally increases normally with age. A hypoxic patient with an elevated AA gradient mostly has one of these three things that we'll see clinically. 1. A VQ mismatch. So there's oxygen in the alveoli, but not a great blood supply. The prototypical VQ mismatch, of course, is a PE, among other things. Or 2. A right to left shunt. When the venous blood is mixing with the arterial blood and it gives you a type of fake out. The alveoli are working, the arteries are working, but there is an inappropriate mixing, either within the pulmonary or cardiac circuits. Or 3. A diffusion defect in which the alveolar membrane impedes gas exchange. The prototype for this is pulmonary fibrosis, for example. You can see that many of these applications are for disease processes that are more common in adults than in children. In short, you can get very far with a VBG in children and use an ABG extremely judiciously. Okay, just to round the discussion out, what about CBG, capillary blood gas? This is exclusively a baby thing. The advantage of a CBG is that you can get a reliable pH just like you can in VBGs and ABGs, but also you can get a reliable PO2 like in an ABG. A capillary blood gas is less painful than an ABG, and it can have less complications in babies. ABG always carries the risk of hematoma and thrombosis, and that's just not an issue with a heel stick CBG. The PCO2 in a CBG, of course, will not be reliable. Now, you can't use a CBG on children who are walking because the heel skin is already forming a callus. So it's really for the in-betweeners that don't necessarily need an arterial stick, but you need to know more than what a VBG could tell you. Just a brief note about umbilical cord gases. Some centers do them routinely to monitor for possible intrapartum hypoxia for the baby. They may compare the values of ABG and VBG run on the umbilical vein and arteries as a snapshot in time as to when the cord was clamped. In the ED, we really won't be doing these, but think about them for the mother who just gave birth in your ED and the child isn't doing well. Remember also that the longer the cord has been clamped, the less useful that gas is, the less useful that measurement is because of ongoing metabolism. All right, in conclusion, in children, if you need to know the pH, go for the VBG. If you're okay with a general picture of the PCO2, you can also use the VBG. If you need something exactly accurate, off by 1 millimeter of mercury, then use end-tidal CO2. Anything else? Think about what utility an ABG would add and whether it's worth the pain and possible complications in small arteries. Just to recap, my personal rule of fours. Now remember, this particular way of looking at the conversion has not been studied. It's just my personal bedside shorthand, but it served me well. The rule of fours. Comparing ABG to VBG, the pH on a VBG will be 0.04 lower. The PCO2 will be 4 lower. And the PO2 will be at least 40 lower. Use the VBG. Save baby arteries. Thank you for listening. Until next time, remember, you are the champion for the child in front of you. Take care.
Thank you for listening to The Playbook. We welcome your comments, questions, and feedback. Email Tim at coach@pemplaybook.org or drop by our website for show notes and more strategy at pemplaybook.org. See you there.